السلام علیکم.
وعلیکم السلام جی.
کاکا دا ویډیو ستاسو اجازت باندې جوړیږي که نه؟
جی بالکل
حاجي
بالکل.
کاکا جي تاسو ته څه مسله وه؟
جی روجې نه څلور ورځې مخکې زما په املا کې بریښ راغلی و او هغه بریښ چې دی نو هغه زما دې خپې ته راکوز
کینې
شوی.
کینې
زما یې خپې ته راکوز شوی دی. جی دا یې خبره کېږي نه. ډېر زیات تکلیف و راته بس اوس دلته کې راغلی یم.
کاکا تاسو لږ دخل ته تللی شئ لږ ګرځېدی شئ.
جی بالکل تللی.
Now I will examine the gait of this patient. راځئ کاکا. As you may see that this patient is giving a history of trauma to the lower back, after which he developed pain and numbness along the lateral side of the thigh and calf and on the dorsum of the foot. Patient is giving a history of typical sciatica, which is a non-specific pain for lower back pain radiating toward the leg. He is unable to do the dorsiflexion of the foot, but he is able to do plantar flexion of the foot. He is also unable to do eversion and inversion of the foot. The reason could be that the dorsiflexion he is unable to do because of the innervation of the anterior tibialis muscle. He is unable to do inversion also due to tibialis anterior muscle involvement. And there was another finding that this patient was unable to do the toe extension. This may be due to involvement of extensor digitorum brevis. So this patient present with the low back pain along the pain and paresthesia along the lateral side of the thigh and calf and the motor involvement. I also checked the reflexes in this patient. Both the bilateral ankle and bilateral knee reflexes was symmetrical and was +2, which was normal. So what do you think about this case? Before going to the diagnosis, you must have a clear concept about the dermatomal and myotomal distribution of the nerve root. This finding is typical with that of a L5 radiculopathy. In L5 radiculopathy, there is a pain and paresthesia along the lateral side of the calf and thigh, and also the patient is unable to do the dorsiflexion. So there will be a foot drop, as you saw in this patient when about examining the gait of this patient. So why this is not L3 and L4? Remember that L4 mediates knee jerk, mainly L3 L4, but mainly L4 mediate knee jerk. So if it was L4 radiculopathy, knee jerk would be lost, and also there will be weakness in the hip flexion, and also there would be weakness in hip adduction, and knee extension would be weak in this patient. Why this is not S1 radiculopathy? This is not S1 radiculopathy because in S1 radiculopathy there is a pain and paresthesia on the posterior calf and sole, and also the ankle reflex would be lost because it is mainly mediated by S1, and there will be weakness of the hip extension due to involvement of the gluteus maximus muscle and foot plantar flexion. In this patient, the foot plantar flexion is normal. So if it was S1, gastrocnemius muscle would be involved and foot plantar flexion would be impaired. So this is not the S1 radiculopathy. So I always take a detailed history and examination before correlating it into your differential diagnosis. I develop a differential diagnosis of L5 radiculopathy, and we will see in MRI whether this finding, we prove this finding clear history based on our history and examination, MRI would confirm or diagnosis or not. So this was a typical case of sciatica, which is a non-specific term for the low back pain that radiate toward the leg. Sciatica nerve is mainly involved by the compression of the nerve root due to either disc herniation or foraminal spinal stenosis. And on straight leg rise test, the patient experiences pain in the leg and the lower back. So always remember the dermatomal and myotomal distribution in order to localize the lesion in the spinal cord or nerve root, and L5S1 is the most commonly involved nerve root, either in compression or foraminal spinal stenosis. So this was it. This is Dr. Bindrar. Until next time, Assalamu alaikum.